They do. Thank you.
Okay. Oh, we can't hear you.
Again, every time I go from, sorry.
Okay, maybe I can't hear. I'll figure out my mic. I'll mute myself.
Marm, can you hear me? Okay, good. So it's great to be with you all, and thank you for all the good and important work that you do in our community, saving lives in your own ways. And I'm going to tell you a little bit about where we are with the COVID-19 pandemic. Things have gotten very real here in Santa Cruz. We still are relatively good compared to our neighboring counties. So our case rate, although it's rising, is much better than our neighboring counties. I'll talk a little bit more about that in a minute, but Susan, if you'll go back one slide, I'm going to start at the beginning here. So I hope that many of you are familiar with this data dashboard. If you're not, it's the best place to find up-to-date numbers on what's happening locally here. It's our public health website. It's easy to find at santacruzhealth.org. So santacruzhealth.org/coronavirus, but if you go to santacruzhealth.org, you'll be able to find this easily. And every day we update the numbers of what's happening with our coronavirus cases in Santa Cruz County. And if you've been watching this, you've seen what's happening there on that graph with those, the orange curve that's going steeper and steeper. That's our case rate. And the blue bar graphs are every day, there's a number of new positive lab tests that we receive at Public Health, and the results, and those are added up and counted. And we've had to adjust the graph in the last 10 days or so to accommodate record numbers of new cases, as you can see there. Again, this is not unexpected or surprising with all of the reopenings that we've had and all of the activity and movement within our community and movement between communities, and the opening of tourism. I'm seeing a black bar in the middle of my screen now. Okay, got it. So just 3 weeks ago, we had 40 active known cases, and that number has rapidly increased. Last week it was around 100, and now we're at 181 active known cases. And I want to bring to everyone's attention that for every known case, there may be as many as 20 or 30 cases that we don't know about. As you've all heard by now, many cases of COVID-19 are not ever symptomatic, or perhaps just mildly symptomatic. And so people may not know that they're ill. So the total number is broken down by those who have recovered, so 275, and then our known deaths. These are deaths not just caused by COVID-19, but a contributing factor of COVID-19 as well. We have an extremely low death rate in the county of Santa Cruz so far. That is likely to change with these increased numbers of cases. We expect that we'll follow state and national trends, and usually a case rate increase that we saw about 2 weeks ago is followed by a hospitalization increase. We're starting to see that now. And about 3 weeks after that, we start to see people on ventilators more. And about 3 weeks after that, we start to see our deaths increase. So we're expecting that we're no different than any other community, and that we're going to see those changes soon. If you look at the source of exposure, the pie graph there, you'll see that almost half of our cases are due to person-to-person spread, and almost all of our new cases are in that category. So when we do our case investigations, we find that they're almost all from multi-household gatherings of friends and family. Often indoors, often over long periods of time, often celebratory events, started with Mother's Day, and then graduations, and then Memorial Day, and those are the kind of gatherings that are riskiest. and that are impacting our community the most. All right, next slide. So if you look at how our cases are distributed throughout the county, we're about half and half men and women. Increasingly, our cases are those 18 to 34-year-olds. And apologies to anyone who's in that age group on this Zoom. But that is an age group that tends to be willing to take more risks, tends to be a little more me-focused, and perhaps not have the greater community involved in mind. That's normal human development for that age group, and less cognizant that their individual behaviors of things like gathering with friends, of not wearing face coverings, of having close contact, physical close contact, puts the entire community at risk. So this is also a state and a national trend that 18 to 34-year age group is growing. The new cases are predominantly in Hispanic communities and predominantly in South County. Again, this is a trend that we're seeing statewide and nationally, that communities of color are hit much harder by this virus than others. And that's not because those people of color are more at risk for the virus per se. We all have the same risk regardless of race or ethnicity or where we live in terms of city or county. It has more to do with what we call the social determinants of health, our housing quality, our poverty, education, crowded housing contributes. More people of color are frontline essential workers and have had to work through this pandemic, unable to work from home. So those kinds of factors. So next slide. The next slide you'll see you can also find online at santacruzhealth.org. And this is one of the many modeling graphs that we use to see where we might be headed in the future. And we are indeed seeing increasing hospitalizations. This is another graph that we had to adjust last week to accommodate new numbers. And yesterday, I know we had the modeling graphs are only updated once a week. That happens on Tuesdays. So later today, you can look again. But I know that we had 14 cases in the hospital yesterday. So we're definitely on the trending toward the higher side of this confidence interval, which would put us into a pretty big surge toward the end of this month, and you know, getting close to hospital capacity. Next slide. So I'm not going to go over all of these numbers, but I just wanted to show you that you can explore the web and find all kinds of interesting data. This is one from the governor's website, covid19.ca.gov. This is also the same website where you'll find all of the governor's guidances about what to do and not to do in your business or other places. And this gives you the state website and also is updated every day. Next slide. You can also find this map at the governor's website. And this is a map that explains what each of the different counties are doing in terms of monitoring. And if you click on our county, this isn't an interactive PowerPoint, so I'm not going to do that. But if you click on Santa Cruz County, you would be able to see our number of new cases, our case rates, our number of deaths, and our number of tests reported. The colors are also something new. They are indicating where we are on the monitoring watch list. So the California Department of Public Health is monitoring the data of all 58 counties. It's available publicly. If you Google CDPH, that's California Department of Public Health, and look for the county monitoring list, you will see all of us, all the different counties, and the counties that are orange are flagged. And you can see that those counties that are orange If they've been flagged for 3 days, they have to close some of their businesses. You can see on the map that most of the counties around us are either closed or they never were opened in the first place. So you can see that Santa Clara and Alameda never got to open all the way because of their high case rates. And a reminder that this pandemic in the US really started in Santa Clara. We know that now. San Benito is still blue. It's turning orange today. So we will pretty much be surrounded. San Mateo north of us and San Francisco are both about to go on the watch list as well. We're probably a few weeks away. I anticipate we'll be there in short order. Our case rate, the case rate that the state requires is that we stay under 100 with a positivity rate less than 8. And we're at about 64 now, our case rate, and our positivity rate is down around 3 last time I looked. So we're still doing okay, but that could change very rapidly, and I anticipate that it will, and that we'll be closing some of our businesses as well. Next slide. So these are the areas that the state has last reopened, the last openings to happen in the state, other than schools, which the state is still intending to open schools for some kind of hybrid in-person at-home model. But some of these are the very same things that are getting closed down by the governor in those orange counties. About 80% of California is already impacted by the governor's closures, and those include indoor activities for the most part. So dining in restaurants and bars, indoor museums, art galleries, indoor entertainment centers like movies, bowling alleys, roller skating rinks, arcades. Next slide. The state is trying to work to message, as are we locally, and this is one of the newer campaigns about face coverings, which we're also now using the word mask, trying to get everyone to comply with the state face covering guidelines. And next. Locally, we have lost control of our ability to monitor and trace every single contact. We have many new contact tracers trained and ready to go, but the state platform is not yet functional, the platform on which they've been trained. And so we have some redundant processes now, and we're really unable to use those contact tracers for the most part right now. So we're scrambling to catch up and trying to stay on top of them. So right now we're focusing on contact tracing and containing outbreaks in congregate settings like our skilled nursing facilities. Testing remains a big problem still. There are supply chain problems all the way up to the global level. That means that even if we have testing machines, we don't have the reagents, the chemicals we need to perform the tests. And that's true even in the state sponsored testing site for free testing in Ramsey Park, where they've had to scale down the number of specimens there that they're able to collect. So in many ways, we feel like we're kind of back in March, where we were scrambling to catch up. Next slide. I think I've gone through most of this, so we can go to the next slide. I wanted to let you know so that you could let your clients, your family members and friends know that if they get a phone call from someone that says CA COVID, that's California COVID, that means it's a contact tracer, and they should answer their phone and talk to the person on the other end so we can figure out if that person might be at risk for COVID and help to contain an outbreak that they may be involved in. If you can spread the word that if people see California COVID, they should answer their phone. All the information they share is protected under HIPAA laws, Health Information Privacy Act. And so nothing's going to be released to any governmental entity or anything that they need to worry about. The next slide. And lastly, I just want to remind you about the pillars of how to keep yourself and your family and our community safe. And that is, as much as possible, you want to maintain that 6-foot physical distance, stay home when you're sick, wear your face covering when you're out and about, wash your hands frequently and cover your coughs and sneezes. A reminder that gatherings are still not permitted with very few exceptions, and that means gathering outside of your own household unit. And it's these behaviors that make a difference in our community about the community spread of COVID-19. So thank you all for everything you've done to date and will be doing in the future. And I'll be available for the rest of the time so that we can answer questions when it's time.
Gail, it looks like there are a few questions in the chat that are specific to you. I wonder if you could answer a question about the number of known cases for youth under 17. Is that due to a lack of youth getting tested, or are we really not seeing any positives there?
It's probably because many of the children who get this virus don't ever develop symptoms. And so they don't know that they're sick and don't know to be tested.
Thank you. I think what we'll do is hold any questions you may have on Dr. Newell's presentation. That was a lot of data to go through. Dr. Kilpatrick will help us be able to think through that data and the implications for us locally. So I think we'll move right to Dr. Kilpatrick's presentation and then have questions at the end. So welcome. Great. Thank you, Gail. Really appreciate that.
Okay, well, good morning, everyone, and it's great to see you all. Hopefully someday we'll get to meet in person, but this is what we have for now. So today, I would like to try to share with you guys some of what we've learned from the science from the last about, I guess it's been 6 months now, amazingly, in this epidemic. And this is I'm not sharing information that I've personally gathered, but basically that I've gathered from other people's science and work, and we'll try to make use of that work for protecting ourselves. So a quick summary of what I want to try to cover today. The first is just to answer the question that maybe I don't even need to address, but I want to be a little bit clear anyways, which is why should we be concerned about COVID-19, especially given that, as Dr. Newell said, it's been relatively, Santa Cruz County has done relatively well. And the answer to that question is that unfortunately things can get bad very, very quickly if we let things get out of control. I next want to talk about the transmission of this virus, which is called SARS coronavirus 2, that causes this disease, COVID-19. The how and who spread this virus, including high-risk activities, low-risk activities, and some exceptions to these patterns. I also want to talk and focus in detail on what we can do to stop the spread, especially as we reopen businesses, organizations, things like that. I'm going to try to suggest that we actually can reduce risk substantially at our organizations, which is great, and hopefully you guys will all be able to help with that. But we're going to have to do one more thing in addition to that, and that is to basically communicate to everyone that just because we're able to reopen businesses and organizations, we also need to follow safe habits in our own personal lives. And so communication and personal responsibility are going to be key messages that we're all going to have to take on board to stay safe. And a key aspect of that is that people are going to need to get tested at the very first sign of their symptoms, and then be provided with safe support if they do test positive. So I'll talk about that in detail in a little bit. And then I also want to address another question, which I think some people have raised, which is, aren't we all going to get infected eventually? And if so, why should we kind of either keep our businesses closed or not get together with our friends? Why delay the inevitable? And I'm going to try to make a strong case that, in fact, from the science side, we're actually developing new treatments all the time. The vaccines are actually moving through progress much more quickly than they've ever done in the past. And just another month or two delay in terms of having a huge epidemic will actually reduce disease and mortality through these new treatments and the deployment of vaccines. Okay, so this first question, there's only been 3 deaths, as Dr. Newell said, from COVID-19 in Santa Cruz. Why should we be especially concerned about this? And that's because things can change very, very fast. And in addition to how quickly things can change, there are delays between infection and illness and death, which Dr. Newell mentioned, that mean that once we see a really big problem in terms of cases in front of us, it's actually too late in terms of hospitalizations and deaths. So I want to show that data specifically for a place where we already have seen an enormous outbreak, and that was in New York City. And so in New York City, in just a 7-day period, the number of confirmed cases went from 70 cases to 2,500 cases. So this enormous growth in just a 7-day period. This was back in March. They did a lockdown just like we had a shelter in place on March 22nd. That's this blue line on this graph here. The x-axis is time, and the y-axis measures both cases, hospitalizations, and deaths. Because of the fact that there's a delay between infection and getting sick, which is about a week, the confirmed cases kept rising even after the lockdown. So there was this lockdown, which is this blue line here, and you might have thought, well, if there was a lockdown, why didn't cases stop immediately after that? And that's because there was already some infections that had not become sicknesses yet, and so confirmed cases kept rising. And in addition to that, which we'll talk about in detail, within household transmission is very hard to stop because, of course, we spend quite a bit of time in close contact with our family members. And so there was some additional within household transmission that occurred after this lockdown. And the result of that is that the peak in infections, which is the black line on this graph, didn't occur until actually more than 2 weeks after the lockdown took effect. So by the time they saw this very fast rise in cases, it was actually too late to stop a much further rise past that. And so that's a huge challenge. So that's the black curve. Hospitalizations are delayed about a week after confirmed cases. And so that's this orange curve at the bottom. So those also rose, but they rose a bit after the cases rose. And then deaths, as Dr. Newell said, occur 2 to 3 weeks after that. And so the deaths actually also rise, but those occur even later. So this rise in cases that peaked a couple weeks after the shelter-in-place order, the peak in deaths actually occurred several weeks after that. So unfortunately, the lockdown in this case in New York was too late, because even though they did it at the relatively early in this overall epidemic, the speed at which things happen and these delays meant that there was still already a bunch of infection that had occurred, and they had the consequences of that for over a month afterwards. And so I want to describe a little bit why things can get so bad so quick with this virus. And that has to do with some things about the properties of the virus and how infectious it is. So it turns out if we live our normal social lives, meaning getting together with our groups of friends in kind of close social contact without masks, then on average, each person will infect about 2.5 other people. And you may have seen in the news or other places, this from an epidemiology perspective is called the reproductive rate of the pathogen, or sometimes abbreviated RT. And so each person infects about 2.5 other people, and we get a new generation of cases about every 4 to 6 days. And so that means that every 4 to 6 days, there's basically the number of cases get multiplied by 2.5. And so if we do a simple kind of math exercise, if you start with 10 cases, then after 10 days, which is 2 of these kind of generations or serial intervals, you'll get 63 cases. 10 more days, you'll get 393 cases, and 10 more days, you'll get 2,500 cases. So as you can hopefully see, in 1 month, just starting from 10 cases, we can end up with thousands and thousands of cases. In addition to that, transmission of COVID-19 is highly variable, and although the average is about 2.5, many people don't infect anyone at all, and many people go on to, a small fraction of people go on to infect many people. And I'll talk about that in a little bit of detail later. So as Dr. Newell indicated, the risk for severe illness with COVID-19 is not the same for everyone. And we can ask, who's at highest risk for severe illness and death? And the answer is older people with pre-existing conditions. But I want to give you more detail than that. So this slide actually shows the chance of someone dying given they get infected. So we call this the infection fatality ratio, or the fatality of COVID-19. And both the graph in the upper right-hand corner, which is over here, and the kind of numbers in this little table here show the chance of you dying given that you get infected for each of the different age categories. As Dr. Newell mentioned, the chance of you actually dying is quite low if you're relatively young. But as you get a bit older, and especially into the kind of 50s and older, the chance of dying given infection rises very, very quickly and is extremely high for older people. In addition to that, there's now a huge amount of data that suggests that the chance of men dying is actually higher than women, and it depends a little bit on the age as well, but it's between 50% and 3 times higher, the chance of men dying than women given infection. In addition, as you've probably heard in the news, there are several other illnesses you might have before you have COVID-19 that also increase your chance of dying, and some of those can triple the chance of dying. The main things that have a huge effect are things like obesity, severe diabetes, and cancers, but there are a number of other conditions that also can contribute. In addition to dying, this disease we now know actually can cause substantial illness that actually can last for a long time. And so earlier on, we weren't quite sure if you might get this and then recover and be fine afterwards, but now we know that actually a substantial number of cases actually have severe illness for quite a while afterwards. So that's an additional consequence besides the actual risk of mortality. So this really, I think, brings up the most important question, which is how is the virus transmitted and what can we do to keep ourselves safe? So the mechanisms of transmission and the risks for transmission all come from a certain type of data, and that is contact tracing or case investigation, where a person gets infected, they get sick, and they go to a doctor, and then a public health team talks to that person and tries to understand how might that person have gotten infected and might they go on to infect other people. So these basically investigations of these cases are how we learn how transmission occurs. And there now are data globally for thousands and thousands of cases. So the patterns that I'm going to give you next reflect this enormous data set. And Dr. Newell, I think, can comment if she likes afterwards, but I think they also reflect the data that we've seen here in Santa Cruz County, and her comments earlier support that. So the highest risk for transmission is when there is sustained, meaning multiple minutes, of close contact, meaning within 6 feet of people, and especially even closer than that. And then if the contact between those two people is unprotected, meaning there's no barrier such as a mask between them, and if that's obviously contact between an infected person and an uninfected person, and especially in enclosed spaces, and especially with poor ventilation. So if we can say that again, the highest risk is sustained close, unmasked or unprotected contact between two people in enclosed spaces, and especially with poor ventilation. So that means that the highest risk for transmission between people is within households, because of course we spend lots of time with people often indoors with sustained contact. In addition to within household transmission, which is the highest, if we share, let's say, a car with someone, public transportation is sometimes challenging. Office rooms can be a high-risk environment, especially if there's close contact without masks, and if there's poor ventilation. The same thing with indoor restaurant dining. There's additional activities besides these settings that are high risk for transmission, and those include things like singing, yelling, talking, vigorous exercise, all those things that basically result in more kind of little droplets coming out of our mouths. Those also increase the risk of transmission. The next tier is lower risk but not zero, and that is if we are indoors but have some distance between people. The risk is lower if we have a shorter duration contact. So if the time between two people is seconds rather than minutes, that's much lower risk. And then the same thing, of course, if we don't have masks. So if you have if you pass by someone in the hallway and you didn't have a mask on and they didn't have a mask on, there is a chance of transmission, but it's much, much lower than these sustained contacts where you're interacting with someone for minutes in a relatively close space. In addition, we now have actually quite a bit of data that suggests, thankfully, that contact with recently contaminated surfaces is possible, but much, much lower risk than the activities that I suggested above. So hand hygiene and things like that are important to do, but we don't need to obsess over those as much as we do need to obsess over not having sustained close contact without masks between people. Finally, even lower risk than everything that I've said so far are outdoor activities, and especially outdoor activities with space between people and masks. And so if you want to engage in social activities, the best way to do it is outdoors with space between people and with masks. And so that means overall, if we try to ask, okay, what can we do to stay safe? We want to minimize our risk by increasing the space between people, increasing the ventilation by possibly going outdoors, and then decreasing the duration of contacts, and of course, obviously wearing masks. In addition to that, if we can, we want to reduce touching surfaces between cleanings. So the next thing I want to try to address, because there's still a little bit of confusion about this, is who can spread the virus, and why can't we stop transmission by asking sick people to stay home? And the answer basically stems from what I'm going to try to explain on this slide here. So the x-axis here is the number of days since infection. So infection occurs at time 0 here. And the y-axis is the relative infectiousness of people. And that's described by this black line, which basically rises here and then peaks and then kind of decays after here to the right. And so the data to make this slide comes from case investigations, as I mentioned before, but also in the time of contact between two people, meaning when did an infected person contact the person that became infected. So we call those infector-infectee pairs. And what I want to try to explain is that when we track back if let's say I was infected and someone had contact with me, when did we have contact relative to when I was infected and when I got sick? So we now know from a lot of data that if we get infected on day 0, our first symptoms start about 5.5 days later, and that's the average, but there's of course variation within that. Most people actually get have their first mild symptoms between 3 and 14 days after they get infected, but the average is about 5.5. But we now know that if you get sick, have your first mild symptoms, things like cough, fever, runny nose, those kinds of things on day 5.5, let's say, day 5 or 6, we now know you are actually infectious 2 to 3 days before that. So in fact, you're infectious on average just 2 or 3 days after you first get infected, and then your infectiousness rises. It actually appears to peak just slightly before you're actually sick, and then it decays afterwards. And so what this means that's really, really crucial is that people that have no symptoms at all, that feel totally fine, they actually can infect other people. And in fact, they're actually most infectious probably just before they have any symptoms. What that implies is that we really need to wear masks, not just when we have, let's say, a cough or a fever or something like that, but we need to wear masks when we feel completely fine, because we're actually at high risk of transmitting the virus when we feel totally okay. In contrast, and I think this has been a little bit confusing, is that the more severe symptoms of COVID-19, things like difficulty breathing, those tend not to occur until substantial delay after your mild symptoms, sometimes on average about a week later. And it turns out that, of course, while we want to be safe then also, a lot of the transmission that we might give rise to actually will have already occurred by the time we feel severely ill. So we need to be really careful both when we feel fine and obviously also when we have mild symptoms. Okay, so since we now know that we can spread the virus when we feel well, we might ask, how do we stop these big spreading events that you've probably all heard of, including things in meat processing factories, jails, communal living facilities, and so on. And we now know when we look carefully at these, what we call super spreading events or large spreading events, that there are several things that contribute to them. The first is that you need a person that's infectious, and then you need some people around them that are susceptible to to infection. There are also some people that have more contacts than other people, maybe due to their job or maybe due to their social activities. These individual characteristics of people, say variation in their infectiousness or susceptibility, are a little bit hard to predict ahead of time. So that's sometimes a little bit challenging to focus control efforts on that, but we obviously all can do some things to reduce our contact rates. In addition, we now know that certain activities greatly increase transmission, and I mentioned these briefly before. These are all these things that involve basically more droplets coming out of your mouth, and so things like talking, singing, yelling, vigorous exercise, things like that, all increase the chances of transmission. In addition, we now know that certain types of settings increase the risk of transmission. So the most important one is a crowded enclosed space. And we now have some additional data that suggests that certain environmental characteristics also increase the survival of the virus. So lower temperatures and lower humidities actually make the virus survive longer. So things like air conditioning actually can be a little bit challenging because they cool things down and keep the air dry, and that allows the virus to do actually a little bit better. So the places that we know that are crowded enclosed spaces, some examples of those that are there all the time are things like prisons, worker dormitories, certain kinds of factories, hospitals, unfortunately, churches, schools, obviously, elder care facilities. All these things are examples of places where there are a lot of people congregating in one place. In addition, there are some types of events that occur that have the same characteristics, but occur just kind of in passing. So the best example of that are things like Dr. Newell mentioned, including parties, weddings. There was a choir practice example many people will have heard of, but basically these are gatherings or groups of people getting together to form a crowded group in an enclosed space. So we now know that these large spreading events are almost always a convergence of all three of these things. They're an infected person that's quite infectious. That person is usually engaging in some activity that makes them even more infectious. So maybe they're singing, maybe they're exercising, maybe they're dancing, things like that. And then if that's actually occurring inside an enclosed space with many other people, that's what gives rise to these large or super spreading events. And so what we need to do to reduce these, of course, is to try to avoid these kinds of settings and activities and protect people that might already have to live or exist in these places. So we now know what the big risky things are that lead to transmission. We can now ask, what can we do to reduce the risk of transmission at work and in our communities? And I'm going to try to go through some of the major tools that we have to do this. So one of the first tools that I think is relatively easy for us all to use are masks. And I want to try to talk about something that's been a little bit confusing, and that is the question about who do masks protect? So there's actually an enormous amount of science about masks now. And the science shows that wearing a mask can protect you from infection, but only a little bit. There's actually a bunch of studies on this now, and it's actually a little bit variable how much protection you get. It depends a bit on what type of mask and how well that mask fits your face. But even the best kinds of masks that fit your face well are not 100% protective. So masks do protect us, and it's good to wear them for ourselves. But what we now know is even more important than that is that wearing a mask protects the people around us. So it protects our friends and family that are near us. And that's because wearing a mask actually reduces the droplets that come out of our mouth when we breathe, cough, sneeze, talk, any of those kinds of things. And the mask can actually reduce that by a substantial amount. So you might ask, if we now know this to be the case, why didn't the CDC have us wear masks back in February and March? And the reasons for that are a couple. One is that there, unfortunately, as Dr. Newell probably can reaffirm, there is still a shortage of surgical and these kind of more specialized called N95 masks. And these are especially needed by people that work with infected people all the time. So nurses, doctors, people like that. And there was a concern that if the public went and bought up all these masks, there wouldn't be enough for our first responders. So there was a concern about that. In addition, early on, there was a substantial concern that people that were wearing masks might actually engage in even more dangerous behavior because they would think that they were especially safe, even when they weren't fully protected. However, given that we now know that people that feel totally fine can spread the virus, CDC realized that it's really important for even healthy people to wear masks to stop those droplets coming out of our mouths. And that's actually more important than these other concerns. So of course, and we've also partly addressed the supply issue with surgical and N95 masks by having us have our homemade masks. So that's why we got to where we are now. So some other tools that we can reduce the transmission of COVID-19. I want to again reaffirm that it's very, very difficult to prevent transmission within households. And that's simply because once you're living with someone, it's quite hard to avoid close contact. And so the main goal that we really want to try to have in front of us is to stop the virus from spreading between households. And what that means is we need to use these tools that Dr. Newell mentioned, which are distance, masks, and settings, specifically outdoor settings, to reduce the risk. So if we can always basically keep the space between people, the more space, the better. If for some reason you have to be within a couple feet of someone, if you can be 3 feet instead of 2 or 4 feet instead of 3, every little bit of extra space you can add is great. 6 feet is a nice kind of guidelines. If you can keep 6 feet, that's great. If you could have 8 or 10 feet, that would be even better too. So we shouldn't totally fixate on a one number, but we should recognize that the more space we have between people, the better. And we definitely want to have at least a decent amount of space, like something around 6 feet is a great guideline. In addition, as I've hopefully tried to convince you, wearing masks, even if you feel totally fine, is really important. And the main reason we do that is partly protect you, but even much more so to protect those around you. In addition, there's now some science coming out that suggests that people that wear masks, that actually serves as a visual reminder to people around them that there's a pandemic going on, and those people tend to give people with masks on a little bit more space. So you're actually kind of signaling or communicating to people, hey, there's a virus out here, can we try to give each other some space? In addition, if possible, if the activities that you want to do on a given day, if they can be done outside, that's going to also reduce the risk of transmission. And if you have to be inside in, say, a one room with another person, it's good to have a better ventilation. And so those are other things we can do to reduce risk. In addition, if we have to be near someone else, if we can make that contact relatively short, that will also greatly reduce the risk of transmission. So if we have to have, let's say, close interaction with someone, masked or unmasked, if we can keep that as short as possible, that will also reduce our risk of transmission. And as I said briefly before, hand hygiene and touching surfaces is also good to do, but turns out to be not as critical as these kind of close direct contacts between people. And what I want to really, really reaffirm, is that everything I have on this slide is important to do both obviously at our businesses, but also in our social gatherings between households. So we need to keep this in mind. One additional tool that Dr. Newell's whole team uses to try to keep us safe is what we call test, trace, and isolate, or test, trace, and quarantine. And unfortunately, this tool is really only effective when people get tested early, or I should say it's actually most effective when we get tested early. And the reason for this comes back to that slide that I talked about before, and that is that if we have a case that gets infected here on day 0, as I mentioned before, that person becomes infectious about 2 or 3 days later, and they start to have mild symptoms around day 5 or 6. If they go get tested right away, then, and we identify them and then they isolate themselves, then we can stop all this transmission that might occur after this red line, which is great. And if that person unfortunately has infected other people during this pre-symptomatic period here when they felt fine but were actually infectious, then when Dr. Newell's team calls them and says, who might you have been close to and had close contact with, can we identify them and see if they might have gotten infected, then we can actually trace the contacts of that person and find some people when they're actually still in this pre-symptomatic phase and have not gone on to transmit it to anyone else. And if we can, then we can actually interrupt the chain of transmission. Unfortunately, if people don't get tested until they have severe symptoms much later, which is say around this time over here when we start to have difficulty breathing and other things, then the person actually has done much of their transmitting already, so we can't really stop them from transmitting as much, and they've actually gone on to infect people, right, back in this time, and this chain of transmission has also gone on to transmit to other people. So if we have these delays where people wait when they have symptoms and don't get tested, then we basically can lose these chains of transmission and let them kind of spiral out of control. So to try to stop that, we need to encourage people as much as possible to get tested at the first sign of mild symptoms. The ways to make that easier for people, of course, is to make it easy or free or both to get tested and also to get the results back fast. And so there's some things that Dr. Newell and her team and other people in Santa Cruz are working on to try to make that easier. In addition to that, it's really quite important to provide people that are infected or that had contact with an infected person with safe isolation space or quarantine space so that they can keep the people that they might live with safe. And then finally, obviously, at the organizational and business level, we need to eliminate any penalties that people might be afraid of if they get tested and find out that they're sick. So we need to really communicate clearly to our employees that they will not be fired or lose pay or things like that if they get sick. And there are some sick pay programs in place at the state level to help with that. Another really probably most important tool we have in this fight against COVID-19 is communication. And so as I hopefully went through in enough detail that we all remember it, the key mechanisms of transmission, these close, sustained, unmasked indoor contacts, we need to recognize what those are, and then we can actually do things in our businesses to reduce that risk substantially in most, but not all businesses. But we also need to communicate to everyone that we also need to follow those same guidelines in our social activities. So we need to signal to everyone that even though businesses have reopened, that doesn't mean we're allowed to engage in our normal social interactions. We can't have close, sustained, unmasked indoor contacts between households. So we can't have these gatherings that Dr. Newell was talking about. And put another way, if we are going to gather with someone else outside of our household, we need that meeting, that getting together, needs to happen outdoors, which is much more safer than indoors. And we still need to keep space between people and also wear masks. And so if we can basically keep these social interactions outdoors in a more safe setting with some distance between people and wearing masks, we will greatly reduce the risk of transmission. I want to end here or finish up here by answering this question of why we shouldn't just let the virus sweep through our communities and get on with things, and are we delaying the inevitable? And the answer is that we are not, and we don't actually all have to get infected eventually. We actually can prevent infection eventually with the vaccine, but actually we can prevent illness and death with some of the new treatments that we have. So let me talk about a couple of those in detail. So the benefits of delaying transmission within our county, and even for each person individually, is that in most places, including Santa Cruz County, a very small fraction of a population has already been infected. And so in Santa Cruz, there aren't really great data, but some estimates from a number of calculations suggest it's probably less than 5%. And that means that if we let the virus spread through our population, it will likely eventually infect about between 30 and 70%, probably around half or more of the people. And if it does, that's going to lead to an enormously large number of hospitalizations and deaths. So we really want to try to avoid that. And in addition, each month we delay infection, we discover new treatments and make progress on vaccines. So as some of you may have heard from the press, there are a couple new drugs that we've been studying that we now know actually reduce mortality. So there's one relatively cheap steroid called dexamethasone that reduces mortality by between 20% and about a third in a subset of COVID-19 patients. There's another drug that actually reduces the amount of time that you're actually in the hospital. So it reduces hospital stays by about 30%. There are also a huge number of vaccines in various stages of development, and there are now 3 that have moved on to what we call stage 3 or large clinical trials. And as soon as one of those vaccines is shown to be effective, then the initial doses that are produced, which are actually already being produced now, can be used to protect individuals at high-risk conditions. So if we can just push off transmission by 1 more month or 2 more months, we will actually be able to use these new tools to reduce the amount of illness and death. And of course, if we can push off transmission for, say, 6 months or something like that, then we'll actually likely have a vaccine that's more and more widely available that can reduce transmission further from there. So I think it's really important for us to see that every month that we can keep transmission low, we gain benefits in terms of our health. So let me close by just saying that we are actually all in this together, and that the course of this pandemic is actually going to come down to our own personal decisions. So if we can, I think it's important for us to make a pact within our own households, and if we can, even within a business. So I think each of you can ask people within your own businesses, if we can make a kind of a pact or a pledge to avoid high-risk behavior, that is to avoid close, sustained, unmasked contacts, especially indoors with other households, that's going to make an enormous impact on the course of this pandemic. And what I want to say kind of more broadly is that we have a personal responsibility, and that is our personal decisions impact everyone that we have close contact with. So if we go and get infected, it doesn't just impact us, but it in fact impacts everyone else that's around us, including our household members and those we work with. And with that, I think we can try to move to questions.
Thank you for Dr. Newell and Dr. Kilpatrick for that just wealth of information. There are a lot of questions in the chat, and so Carmen and Susan and I will be surfing the chat and reading the questions out loud for you, Dr. Marm, and you, Dr. Gail, to help find answers to. We may not get to all the questions in the chat, but we're going to do our best. How does that sound? Give me a thumbs up. All right. So very quickly, what can people do in their own homes when they live with a lot of people? And as you know, we have high density living situations, especially in South County and low income communities. What is the reminder that we need to give people, and or how can we support information getting to people?
So I think if we can, is to communicate what are these high risk activities. And so I think the best way to keep your household safe, especially if your household is a large number of people, which as you're communicating, Mary Lane, I think that's a fact of life for many people, it's to have everyone in that community make a pact with each other. If everyone is safe, then the virus can't get in the household, because once it does, it's hard to keep it from spreading. So I think that's the number one thing I would say, is to have everyone in that household make a pact and say, hey, we're all in this together. If we can all be safe, we will keep each other safe. If someone within that household does start to have symptoms and get sick, then I think the biggest thing that we can do is basically try to get tested as soon as possible, because that's going to reduce the chance that you've actually already gone on to infect members of your household. And if that can be, if that person can be identified, and I don't mean in a kind of privacy exposing kind of way, but basically if that person can know that they're infected, then we can go in and try to give that person safe space to isolate themselves until they clear the virus from their system. And that will reduce the chance that they actually spread it to their other household members. And of course, we can then also try to make sure that everyone else in that same household can also be tested and protected. And so I think those would be the main things I would try to suggest that people do, is make those internal pacts with their own households, and then at the first sign of any symptoms, get tested so that you can protect everyone else around you. Dr. Newell, did you want to add comments to that?
You did a fantastic job, very thorough.
Thank you.
Dr. Newell, will you share a little bit about what's being done in the county in terms of space for people if they test positive?
Yes, so I was going to add that if anyone in that crowded household is feeling ill, every effort should be made to isolate them as much as possible. So if possible, have them in their own bedroom and their own bathroom. Now, I know in crowded housing, that's usually not possible, but if you can do it very briefly until their test result comes back, then we at least know if they're infected or not. If they are infected, then we at Public Health and the county, through Human Services Department, have housing options to help alleviate some of that crowding household problem. We're running up against tourist season, and we had this problem over the 4th of July weekend, that some crowded household cases needed hotel rooms. That's where we've been housing people, and there weren't any available because the hotels were fully booked all through the county, and all the vacation rentals and Airbnbs and all of those. So we're now exploring other options. The county does have leases currently with 5 hotels. Many of those rooms are full. They're all fully booked, with mostly with people who are at risk and otherwise would be unsheltered. So we've sheltered about 40% of our previously unsheltered homeless population. And they're in those 5 hotels, and they got prioritized according to age and medical conditions that would put them at risk. So now with this hotel shortage, we're looking at other options. So we're looking at talking to UC Santa Cruz about possibly being able to use their dorms for some period of time, especially the single rooms where we could do isolation quarantine. We're talking with Dominican Hospital about using their old Frederick Street facility for that, leasing that from them. And then also possibly talking to Watsonville Community Hospital about their empty wing. So those are some of the areas that we're exploring.
Excellent, thank you. I'm going to read a couple more questions and then I'll invite Carmen to jump in to help me read questions. Can any work be done with housing associations to post literature in English and Spanish? Please work with apartment complexes and units and housing associations to offer free materials that are easy to read and with visuals. Can you talk a little bit about education and outreach and some of the areas that the county is moving forward?
So there's a group out of Pajaro Valley that is trying to, or working to develop culturally appropriate educational materials, graphics, and multi-languages, and trying to get a more targeted messaging approach to the South County population in particular. And I know the Community Foundation and the county are helping to support that both administratively and financially. So we're doing a lot of educational material production already. Some of it's available on our website and can be easily printed. I've also seen on the Santa Cruz Visitors website a new social media campaign around taking the safety pledge for COVID safety. And any of those materials are freely usable and can be distributed throughout the county. So
Excellent.
Any of your organizations could do that.
Excellent. Can you speak to Appendix A and what should nonprofits know about that special document?
Yeah, so Appendix A, it's, for one thing, I want to tell you it's being revised and updated to include things like you can use your own reusable shopping bag at grocery stores now. So that's one of the changes on Appendix A. It used to be required to be completed, implemented, and posted at the front door. That's optional at this point, but it's still a fantastic exercise and a good way to start to make sure that your organization is following the safety rules. So that's a good place to start your safety procedures.
Thank you, Dr. Gail. Carmen, I'm going to pass it over to you.
Thank you. Yeah, so there's a question here about us telling more about the role of young children as asymptomatic carriers and the implications of group care with your young children who are young and are too young to be reliable to wear masks. So risks for children and adults.
Do you want me to take that, Dr. Newell?
Yes.
So there's actually a huge amount of science on this question, and I want to be clear that there's actually some still uncertainties about this. So as Dr. Newell mentioned earlier, there's very strong data showing that the risk of symptoms at all, and especially severe symptoms, increases with age. So younger people are more likely to get sick. In addition to that, put another way, especially young people are actually much more likely to have no symptoms at all. So we've known that now. That's been very clear for several months. A big question that we didn't really know several months ago was, can children get infected even though they don't get sick, and can they go on to spread the virus? And so now, just in the past, I guess about a month or so, there's been a growing amount of data that now shows us that children can definitely get infected. And in fact, there's only relatively weak evidence that they're any less susceptible to infection than adults. So it looks like children are either equally or just slightly less susceptible to infection than adults, meaning that we shouldn't at all treat them as being kind of immune to this virus or invulnerable to this virus. In addition, we now have enough evidence that suggests that children definitely can also spread the virus, both from one child to the next and also from one child to an adult. And so most of the early data that we had was from places where there'd been shelters in place or lockdowns, and there was basically not very many kids hanging out with other kids because there weren't schools happening. We now know that there's been a bunch of reopenings of schools in both Europe and in Asia, and we now actually have some good, unfortunately, case data that show that there, excuse me, definitely can be children-to-children transmission and children-to-adult transmission. Whether or not children are equally infectious or slightly less infectious is still not fully worked out. There's some data that suggests they're either equally or maybe a little bit less infectious. That's still not fully worked out. But there's plenty enough data to now know that there is a risk of a child becoming infected and then transmitting that virus to both other children and to adults. And all of the data we have so far suggests it's by the exact same mechanisms that adults spread the virus. So it's basically this kind of close sustained contact where the two children or a child and an adult are within a few feet of each other for a number of minutes, and especially without masks. So I think, Carmen, thank you for that question. And I think the answer, unfortunately, is that the exact same tools that we would use to reduce transmission between adults apply to children. And that means that if they can't wear a mask, because I think children definitely don't always do the things that we ask them to do, then we need to try to set up the settings or circumstances so that they can be safer. So that means that I think gatherings of a bunch of children are going to be certainly at higher risk than people if people are basically playing with people in their own household, right? So that's going to be a higher risk. If the children are gathering indoors, that's going to be a higher risk than them gathering outdoors, and all those kinds of things. If there are things that children can do that have a little bit of space, more space between them, that's going to be safer than if they're kind of wrestling around with each other and in close contact. So I think those are schools and children in general present an extra risk than adults, just because I think understandably they like to have fun by rolling around and kind of being close with each other. And that basically, unfortunately, elevates the risk of transmission. So I think it's a really difficult problem. Obviously, it influences many, many things in our society, but I think we need to keep the same transmission mechanisms in mind, of the same things that contribute to high risk of transmission between adults apply directly to children as well.
As a follow-up to that, are minors able to get tested at the Ramsey Park facility?
Dr. Newell can comment on that one. Yes, she's saying yes.
Okay. Yeah, I was. So another question is about information that is being given to the hotels where guest workers are being housed. So is there something special being done there?
Dr. Newell, can you comment?
Carmen, are you talking about the H-2A visa workers from Mexico?
I think that's the case, yes. So they're in hotels, and so how are they being, informed about prevention and health?
We've been working closely with the agriculture community, as has Monterey, and we're working collaboratively with Monterey County on this. And the growers, owners, operators are providing materials for all of their workers, not just the visiting workers, and are requiring face coverings and physical distancing, and providing the best that they can for the working circumstances. Generally, the field work, the packing work can accommodate the social distancing requirements. Where we're having trouble is transport to and from the fields, from the housing. So even though they're running extra buses and extra trucks, the folks tend to be crowded into transportation to get to the fields and from the fields. And so that and the housing, crowded housing situations are all worrisome. In addition, the federal government in this H-2A visa program does not require any testing prior to departing for the US, and neither is testing required once they arrive. So that is definitely a leaky point in the bucket.
Mm-hmm. Carmen, do you want to ask a couple more, and then we'll tag team to Susan?
Yeah, I'll do that. So there's a question about what does the latest data show regarding reinfection and antibody development, and I will add to that, if you could elaborate a little more on the health, long-term health consequences in a person that had the infection, and that was sick. So
sure.
That it's all about you, Marm.
No problem. Yeah, so so there's been a bunch of studies, and people have seen things in the news that were initially concerning, but now we actually understand them much better. So many people have seen reports that said, oh, there are patients that got sick, were infected, we tested them, we know they had COVID-19, they recovered, they seemed fine, and then a few weeks later we tested them again and they seem to be infected again. And so so let me take the opportunity now to try to give us all one tool for interpreting press stories as we read them, and that is that the tests that we do for COVID-19 are actually for a piece of the it's called an RNA, the little kind of part of the virus molecule, not for the live virus itself. So we're actually just seeing if there's a fragment of the virus around, and the result of that is that sometimes we can test both people or surfaces and find fragments of the virus, but it does not always mean that the person or that the virus there is actually infectious. And so we now know from actually a ton of work that these people that get infected and are sick and then recover, they feel better, and they test negative and then go on later to test positive, we now know that that is just their body shedding additional fragments of the virus, but they are not infectious anymore. So there's now been actually a huge number of studies of people that have had these kind of recurrent shedding of these pieces of the virus, the RNA, that they have actually not found any one of these people to spread the virus to anyone else after they've recovered. So basically, the evidence now is as clear as it could possibly be. I actually know of no exceptions to this data, which is that if you recover and clear the virus, you may go on to shed more virus later, but there is actually literally no evidence of those people ever going on to infect a person after that. So that's great. It means that we don't have people that get sick, get infected, and then periodically start shedding the virus again, which we actually know can occur with some other viruses, but we definitely do not have any evidence that occurs with COVID-19. So that's great. The second part of your question, Carmen, is what about these antibodies that our body makes? Aren't there tests out there that we can use to test ourselves, and what does that mean? And the answer is yes. When we get exposed to new viruses like this, our immune system mounts a response, and one of the ways that it responds is by making little proteins called antibodies, and those antibodies provide some form of protection against the virus. And we now have many, many commercial tests that can test for the presence of those antibodies. Unfortunately, we don't quite know yet what and how much what having antibodies means and how much antibodies we need to be protected against infection. And so so we can take a test which will tell us whether or not we've been exposed to the virus in the past, and those tests are actually some are better than others, but there are some that are quite good. But unfortunately, even if we get a positive antibody test, we do not have strong evidence yet that we are then immune to infection. So it's likely that infection once will convey some form of protection afterwards, but we don't know the extent of that yet. We don't know if that means you're fully protected, meaning you're not going to get sick and not going to get infected, or it might mean that if you get exposed again, you might get slightly infected but not get as sick. That's a possibility. We see that with some other diseases. It's possible you might be protected against disease but not infection. So we know that you might actually be able to get the virus and get it again but not feel sick, but still actually go on to infect people around you. So those uncertainties which still exist now, and the main reason they exist is because this virus has only been in our communities in human populations for a few months. So we can't know yet if you get infected, let's say a month ago, a month later, are you still protected? Or are you just protected for a few weeks afterwards? Or might you have immunity for a year or two? So those are still huge open questions in science. In fact, those are some of the biggest questions we have in science right now, is how long and how good previous exposure or immunity from previous exposure is. I will say one last small thing, which is that these antibody tests, they're quite good, some of them, but even the best ones I've seen in all the hundreds that are available out there, they still have a chance of a false positive, which means for some people, you can take a test, get a positive result, and in fact, it not mean what you think it means. The test makes you think you have antibodies or have been previously exposed, but in fact you haven't. So even the best tests I've seen are not 100% perfect, and that means that you have a chance of a false positive, which means you actually don't have any protection at all. So I would encourage anyone that is interested and wants to get, if they have this strong curiosity to know whether they've been exposed or not, they can. But unfortunately, no matter what that test comes back and says, that does not mean we should then, if we get a positive antibody test, we're safe, we're good. That does not mean that at all. It means that we have some evidence of previous exposure, but we don't know how protected we are after that point. I think the last part of that question, Carmen, was what about these lingering symptoms? We now know that a number of the symptoms that people can get from COVID-19, especially things like fatigue, but some of the other ones as well, there's a number of other symptoms that we now know can actually last on the order of months. So we actually have only had the virus around in our communities for about 6 months. We don't know how long yet, but they're actually a substantial fraction. It's a non-trivial amount of people that get sick, and then partly recover, but don't fully recover. And people can read many, many stories about that online if they like. And so I think the importance of knowing that is that we shouldn't think of this as, there's a small chance of dying, and if I don't die, I recover just fine. It's not that big of a deal. In fact, if people get infected with this and get sick, there's a chance that that sickness will last a long, long time, like months and months and months. So that's, I think, an additional threat that is sometimes underplayed in the media that might count deaths, but not count these severe lingering illnesses.
But is there like a concept when something is going to happen to your body that will never recover, you'll never recover? Because I've seen some of that in the news or in media, social media.
So the answer to that, Carmen, is that we simply don't know how long that will last yet, because we've only had infections, the first infections in the US were in March. And so we're only 3 or 4 months from there. So there are unfortunately people that still have symptoms now 3 months later. We don't know if those people will get better in month 6 or actually have these symptoms for the rest of their life. But I think a 3-month illness to me is, bad enough that I think that's good reason for us all to recognize this is a very severe threat.
Dr. Kilpatrick, there are a few more questions about the virus and testing. One is about if you think you've been in a high-risk situation, when is the best time to get tested? Also, if you get a negative result, does that apply to your whole household, or a positive result? Is there any assumption that we can make from a test result for a household?
Sure.
That's one set of questions, and then we can talk more about the virus.
Okay, great.
Yeah.
So that question is actually a great question, and unfortunately has a slightly tricky answer. So if we are in a risky situation, say we had a contact with an infected person, or we may have just maybe went to a gathering where there are many people at the gathering, we weren't sure if we had a risky contact. If we get tested and the test is positive, then that actually is that information is very accurate. So this test the test for the actual virus, let me actually take one step back briefly and just say that there are 2 kinds of tests. There's a test for the actual infection, that's for the viral RNA, the piece of the virus in your body, and there's another test for the antibodies, and that's for past exposure. So what we want to be clear about now is we're saying if we think we might be infected, we will get this test for the actual pieces of the virus, the RNA, and that test, the kind of infection test or RNA test, is very, very accurate in terms of not ever having false positives. So if that test is your positive, the chance of that not being true, unfortunately, is very, very low. So that test is very accurate on that side. Unfortunately, that same test sometimes misses infections, and it definitely can miss infections early after you become infected. So if I, let's say, had a risky contact yesterday and I got tested today, if I get a positive result, then I actually know that I am infected. So that part is very clear. Unfortunately, if I get a negative result, that does not mean that I'm definitely uninfected, because we now know that when you get infected with the virus, it takes a little bit of time for the virus to replicate in our body to high enough levels that a swab, which is the normal technique that we use to sample people, will show up positive. And the exact number of days that it takes before we get infected and we test positive is actually still also a bit unknown. We don't have really good data on that yet. So you can then say, if I have a risky contact, or I actually, let's say, have a contact with a known infected person, can I just get a test and find out if I'm fine? And the answer, unfortunately, is no. The test can find infection, but it can't rule out infection. And what that means, and Dr. Newell probably can emphasize this as well, is that if we end up having had close contact with a case, no matter what the test says, we still have to be safe and isolate ourselves. So the standard protocol that we all try to do is that if we are a close contact, meaning we had, say, within 6 feet, several minutes long contact with a case that was infected and no masks, then we need to then isolate ourselves or quarantine ourselves from other people for 14 days, which is about the time in which we will find out for sure whether you're infected or not. So unfortunately, we can't use testing to rule out infection, especially when people don't have symptoms. So if you do have symptoms and you get tested and it's negative, then we now know that the accuracy of that is pretty good. So in the first few days of symptoms, about 90% or more people that are infected will test positive. So a negative test then provides us with some information. Unfortunately, and slightly strangely, if we have no symptoms and we get a negative test, you think that means we're good, right? And the answer is no, unfortunately. It could just mean that the virus is in your body at low levels and it's not detectable yet. But in fact, in a couple days, you may go on to get get sick and be quite infectious. And so that means that, unfortunately, testing cannot be used as a tool to rule out infection. And that means that we really need to try to avoid these close contacts, these risky contacts, because if we don't, we may get ourselves in a place where we have to basically quarantine ourselves for 2 weeks. And that's obviously a very substantial impact on both ourselves and the community around us. Did you want to add to that, Dr. Newell?
Just to acknowledge that that idea of quarantining, which is really important in prevention of spread, is a very difficult concept and very difficult to carry out in reality. Because to ask someone to stay at home and away from others in their household even for 14 days because they might be sick, that's really a big sacrifice to make. It might mean 14 days of lost income, although most people can get some kind of income replacement from state programs or philanthropic efforts. But it's a big ask and something that we're definitely not used to doing in our society.
So if I can just reemphasize that the safest way to avoid that is to basically not have those high-risk contacts with other people, and that will minimize the chance that we have to have these kinds of quarantines for each individual person. So the fewer close contacts that each person has, the less people we will have to quarantine because it's a very challenging endeavor. Thank you.
Right, so back to the childcare question and our very young children and the elementary schools when they reopen, what we're recommending is that the children stay in small, stable groups. So that means the same children, 10 to 12 is the ideal size, but I think realistically our schools may have to go up to 15. And it should be the same children all day, every day, and the same teachers with those groups. So that creates a kind of a bubble that those children, instead of being exposed to hundreds of children every day, they're only exposed to a small number. And it also helps to protect the teacher, and it also helps to protect the families of those children by keeping those bubbles small.
Dr. Kilpatrick, there were also questions about the nature of the virus. Is it airborne? And if someone has been infected and is in an enclosed space and leaves that space, does the virus linger in that space? So if you could address the airborne issue, I think many people are confused after some of the journalism released yesterday.
Sure. Yeah. So let me say this in the most accurate way possible, which is going to be a little bit less clear than just giving you a blanket statement. So we now have an enormous amount of data that shows us two things very clearly. The very clear thing is that almost all, but not all, transmission can be explained by close contact without masks between people. So this kind of within a few feet, direct contact with people. There are a few, and I want to emphasize a very small fraction of cases that are very hard or maybe even impossible to explain that way. And so the most accurate way to present the science is that the highest, absolutely highest risk for transmission are these very close, unprotected contacts, so unmasked, close contacts, and especially ones that last some time. So there's been a bunch of case investigations that look at people that we now know were infected. Let's say went to a wedding. Actually I read a paper last night about a really nice case study where there was a wedding and actually a bunch of gatherings and an infected person. And there were many, many brief contacts between the infected person and other people, and there were some lengthy contacts. And the transmission events that occurred were all from very sustained contacts. So I think this tells me two things. It's comforting in that if we briefly walk by someone that's infected, that we know is infected, let's say on the street, outside, in any sort of setting like that, even indoors in a hallway or something like that, if we simply pass by them or exchange maybe one or two words with them, the chance that we get infected is extremely low. So very, very, very low. However, if that person is infected and we spend minutes talking to them, that risk skyrockets very quickly. So that's great, and that enables us to know what we should do to focus on. In addition to that, unfortunately, there is a small possibility, not a huge possibility, but a small possibility that the virus can travel for more than 6 feet. So basically you could be more than 6 feet from someone and still get infected. But all of the examples of that exist, and there actually are only a few in all the case investigations that have been done that are conclusive, those all come down to enclosed spaces. There's no evidence of the virus jumping 15 feet outdoors between two people that pass each other quickly. That's simply not ever been observed. So I think we can not necessarily say it's zero risk, but it's so small, I think we don't need to worry about those kinds of interactions. However, if I was in an enclosed space with another person that was not wearing a mask, even if I was 10 feet from them for several hours, that could be a risky activity. So what that means is that we need to avoid those things. And the way we avoid those things is by asking everyone to wear a mask, not just me, but also you. So everyone in that enclosed space wears a mask. And the more distance we can have, the better. And if it's enclosed, if we can have some ventilation as well, so that the virus basically, as we emit these droplets, it doesn't kind of build up, but it gets removed from that room, all those things will help. So there's actually also an additional study that I read in great detail again recently, and that was on a bus, which is actually relevant to Dr. Newell's comments earlier. And it was very interesting in that the infected person went on to infect people right around them, but also some people a little bit further away, but no one that was near a window. So this provides us with additional evidence that that basically increasing ventilation and basically not being stuck in an enclosed space with kind of a fixed amount of air that's not going anywhere, that also substantially elevates transmission. So what I hopefully will try to communicate clearly now and summarize all that is to say that the thing we really need to avoid is these close direct contacts between people, but also we also should try to avoid being in an enclosed space with people, even with a little bit of distance between people, if there's poor ventilation in that space. So we need to do those things that we can to increase ventilation. So for example, I hope that on these transport buses that they're being used to move the farm workers around, especially because Santa Cruz in the summertime doesn't have much rain, I think the windows on all those buses should be kept down as much as possible. If we can apply the exact same things to our organization, so I think most people that are on the call today will have office spaces that they're trying to manage. If we're going to have more than one person in a room in an office space, let's have distance between them, let's have masks on at all times, and let's have some ventilation in that space. If you can have windows open and things like that, that's going to minimize the risk in those spaces. I will also say that there is either none or maybe one or two extremely weak examples of the virus lingering in airspace after someone's left. So with other viruses, that actually is a possibility. Things like measles and that actually can be transmitted by between one person and the other person that never even see each other. And so thankfully, this virus is not like that. We actually have no evidence of, say, someone going into an elevator, leaving the elevator, and 10 minutes later, someone else using the same elevator and getting infected. That's actually not really been observed so far, which is great. There's one or two cases where we might have seen a possibility of surface contact, but they're literally just, you can point to the only ones in the entire world. So, so I think that we should not see those as giant risks at all. We can do simple, small things that can help. So for example, what if you had to use a porta potty outdoors in say an agricultural environment? That's where you had to use the bathroom. If it was me, the person went in before me, if they didn't have a mask on, I would probably open the door, let the breeze come in for 15, 20, 30 seconds before I would go in, and then I would feel much, much safer, and I wouldn't worry about that so much. So, so I think if we can, let's recognize the small possibility of the virus moving more than 6 feet, and let's recognize that when that ever has occurred so far, that's always occurred in an enclosed space and in a place with poor ventilation. So those two things together can help us a lot in reducing the risk of this, what we call either aerosol or airborne, or all these are the same kind of words that people might have heard. So the science is very clear that it's possible, but it's extremely low probability. And so the combination of those two things I hope can help us to focus our energy on those most risky things and the ways that we can reduce this low probability event.
Marm, if you could follow up, there's a number of people on the call who are teachers or work with children, and some questions around, should we be doing temperature checks? Is that useful? And then also, I think for Dr. Newell, there's a policy question on the table around how is this going to work with children going back maybe half-time in 50% groups to school, and then their parents needing to go back to work are likely to be making other more haphazard childcare arrangements. How are we going to manage that? And is that sensible policy? I feel like is probably the question, given how stressed parents are going to be trying to organize this and keep those bubbles intact throughout the work week. So temperature checks maybe first, and then
Sure.
policy around how to support families and children.
Sure. So the symptomatic screening, which is the kind of general term for basically temperature checks and things like that, is a tool that can be used at low cost to try to help a little bit. But I think if we can, let's think about it that way, as being a small tool that we can use to help a little bit, but by no means a way to make sure that someone is uninfected. We cannot use symptoms to rule out infection. And the reasons for that are twofold. One is, as I tried to hopefully convey, we now have really good evidence that you are infectious before you have any symptoms at all. So you're basically going to miss those people. In addition to that, the types of symptoms that people get when they're infected with COVID-19 are very diverse. And unfortunately, fever shows up in about a third or even less in some populations. And that means that if we just use a temperature thermometer to find infected people, we're going to miss all the people that are infected but have no symptoms, and we're going to miss 2/3 of the people that have some symptoms because they don't have a fever. So a temperature check, is it useful? Well, sure, if it costs you almost no money and no time, you can still find the people that have a slight fever that don't notice it, right? So is it a little bit of a useful tool? Sure, if it's very fast and easy. But I would argue that the data suggests that it's going to be a very small, partially effective tool. If we want to use symptom screening at all, there's now really good evidence that that cough is more common than a fever. And so a cough plus a fever would be a nice combination, rather than just a fever would be one way to try to find a few more symptomatic people. And in fact, cough plus fever, if those two symptoms show up together, then the chance that they actually have COVID-19 are much, much higher than any one of those things by themselves. So what I will say is that we have a little window of time in which symptomatic screening is going to be moderately effective, or at least partly effective, let's say it that way, because now in the summertime, there aren't that many colds or that many flus. Unfortunately, come September, October, November, when cold and flu season start, we're going to be in a really tough spot, because they're just going to be, especially in children, a bazillion people that are going to have coughs, fevers, runny noses, things like that from mild illnesses that aren't going to be COVID-19. It's going to make it very hard for us to differentiate COVID-19 from other stuff. So that challenge, as I see going forwards, is going to be huge. And so if I had a one wish, it would be for us to try to do our best to get the virus under control now, when we have a chance to really differentiate symptomatic things from being COVID-19 and other things, because when it comes to the fall and winter, it's going to be much, much more difficult. So so that's what I would say. Symptom screening can be a partly effective tool, but we need to recognize it as only very partly effective, and it should be viewed as something that, if it can be done easily and quickly, it can be useful. But if it's a huge to do that, I think the benefit is going to be relatively smaller. So so I think those places that can set up a really quick, easy scheme to do that, and maybe just have people do a quick check. Hey, how are you feeling today? Do you have a hint of a cough, a fever, any other symptoms like that? Maybe even have a list. There's a list. The CDC's website has, I think, 10 or 12 symptoms. If people just want to scan that list over a 20-second period of time each morning and ask themselves, do I feel any of these things? I think that's useful. If we try to use it as a criteria for which, if someone has no symptoms, they're safe, it's definitely not going to be effective for that. So Dr. Newell, do you want to take the much harder question about how we try to keep everyone safe with schools opening and people going back to their jobs? That seems hard to me.
That's hard. So the governor has issued very specific guidance around daycare and about schools. And the governor's guidance is legally mandated. So they are basically orders. That guidance is to be followed as if it were orders. That can be found on that governor's website online. There's actually now 26 different kinds of guidelines for different kinds of activities. Each one of those is many pages long and very detailed. So whatever your work site or your work situation, you'll be able to find specific guidance there. And so I'm meeting with the County Office of Education and the 13 district superintendents on a weekly basis to try to set up some policies and procedures to allow our children to go back to school in fall, in August, at least part-time. This is going to be really challenging, and we have to acknowledge that it puts the children and their families at risk of COVID, and the teachers and staff. So we're going to do whatever we can to minimize that, but child development experts are telling us it's very important that our children are back interacting with other children, back in some kind of education system. And so we're trying to do that as safely as possible. So that guidance is what we're following. There's also very specific guidelines from the California Department of Education and from the CDC around returning to school. So all of those are good resources. The school districts are planning to offer preschool, so pre-kindergarten, and they're planning to offer after-school care as well. So they're planning their programming to accommodate full-time working parents. But as was already mentioned, that means that those social bubbles will be broken at least once during the day, and a new social bubble will be introduced. I know the smaller school districts will probably have greater luck at keeping those bubbles smaller and duplicating each other from classroom to after school care. It's going to be harder the bigger the setting.
Thank you so much, Dr. Gail and Dr. Kilpatrick. We're at the end of our time, which flew by. It has been incredibly important to bring you closer to the nonprofit service providers. And so we're very grateful for your time and sharing of expertise. There are many questions that we didn't get to and some logistical questions for nonprofit leadership to go back and think about with their teams. And so we'd like to invite you both to come back to speak to this group. I know you have a lot of requests on your plate, but I feel that this is an important, and as you can see by the number of people on this call, that there is a hunger and a need and a gap with these service providers. And so I'm going to pass it over to Susan to close this up. I want to thank Carmen and Susan for helping us pull this together, and thank you for your expertise and helping us understand what is the impacts and what we can do in our community.
Thank you, Maria Elena. I just put my email in the chat, and I would welcome you all to, I know we have some unanswered questions here, especially around how contact tracing works, around messaging overall, especially around needs in South County and making sure that we don't create or reinforce negative stereotypes, more on testing. So I know there's a lot of questions we haven't been able to get to, so I invite you to send them to me by email. Our team will collate them and work with our two doctors here to help us answer them, and we can post this with the recording on our website, so we can send this back out to each of you when they're up.
Can I say one last thing before we finish?
Yeah, go ahead, please.
Yeah, so I guess I just want, if I can, just to really emphasize two things. One is, one of the things I was really hoping to do is give you guys all tools, right? So while there is a huge amount of information out there that can be, I think, overwhelming and confusing, I've tried to really distill down the most important thing, which you can look at this is recorded, so you can look back at the slide, is that high risk, kind of low risk activity slide. That provides you with a set of tools to evaluate any situation yourself, to ask, what are the things that I really must do? And what are the things that I can do to help a little bit, but are not as important? So I feel like that's really important. And the next, maybe even more important than that, or I guess directly related to that, is that if we can all use those tools together, each make our own personal decisions to choose to have certain kinds of interaction and avoid certain kinds of interactions, those are really what's going to help us get through this epidemic. And so if we can arm ourselves with the information, which I hope I've tried to give you the best we have from the science side, and then make personal decisions, I really feel like that's our way out of this. If we don't do those two things, we're going to be in for a really, really, really tough time. We're going to have cycling of spikes in cases and illness, economic shutdowns, loss of jobs, all that kind of stuff, and then cycling back again as we try to reopen and close back up again. And I feel like that's a trajectory we want to go down. And the way for us to stop that is those tools that we have together and these kind of personal decisions we have to make, both ourselves and everyone in our communities and households and businesses. So I hope that I didn't take up too much extra time, but I just wanted to really emphasize those as like the most important things that I can possibly imagine us getting from this meeting today.
So keep your distance, keep your mask on, stay in outdoor or well-ventilated spaces, and keep your contacts brief. Is that your message?
That's fantastic. That's
okay.
Great. Yeah.
Well, we so much appreciate everyone's participation. Thank you very, very, very much to Dr. Newell and Dr. Kilpatrick. And Maria, Elena, and Carmen, thank you for making sure that this happened today. And we appreciate your participation. For those of you whose faces we could see, it was lovely to get to see you again. So thanks, everyone.
Take care.